They're a little painful for the patient, but that tube can migrate between the back teeth as well. And so even if you don't see the front teeth biting on the tube, you may want to take a peek at the back teeth. Make sure that that tube hasn't gotten lodged in between the teeth. The patient may not even know they're doing it. If the patient is not biting, then check for the tube position. Where was it supposed to be? Because, of course, you checked that at the beginning of your shift. Where is it supposed to be, and where is it now? And is it up against an airway? Is it hanging out right on top of the carina? Where's the end of that tube, and is it lodged up against something? If none of those are the problem, then we may need to start looking at causes of increased airway resistance or decreased compliance. If your patient is in volume ventilation, the ventilator will keep pushing that breath until the preset volume is reached. Therefore, if your patient has a decreasing lung compliance or increasing airway resistance, which again indicates a change in patient condition, this is going to take an increased amount of pressure to get that breath in because it just takes more force. If your patient is in pressure ventilation, decreasing lung compliance or increasing airway resistance would actually make them receive less volume because pressure is preset. So in this situation, we're in volume ventilation. If we go back one slide, please. We're in volume ventilation. The pressure alarm is going off, which means we likely have something causing our compliance or resistance to change. So some potential causes, we've talked about secretions, which has a fairly easy fix. Bronchospasm, another fairly easy fix. If your patient is truly having a bronchospasm, then some sort of bronchodilator may be a good idea. But remember that all that wheezes is not